This meeting is now being recorded.
Hi, thanks for joining us today for the webinar. We have a Midwife Lauren Pasche here to discuss your daughter's first gynecology visit. And I'm Donna Karras. I coordinate the webinars and classes for the Valley Hospitals. Two things to share with you first. I'm recording the webinar, so I will send it to you later this week in an email. And if you have any questions for Lauren, we have a Q&A tab at the top of the screen. Just click on that and enter your questions, and Lauren will answer questions midway through and at the end. Now let me turn this over to Lauren.
Hello, everybody. My name is Lauren Pasche. I'm a certified nurse midwife who works here at Stillwater Medical Group. And today we are going to talk about your daughter's first visit to the gynecologist. The objectives of this webinar are going to be to gain a better understanding of gynecological care of young women, to review the different kind of visit types that we see here in clinic, and to provide you with any tools and answer any questions you have that will help you and your daughters feel comfortable during this first visit. So the first question is, what is a gynecologist? And in this practice here, we have three different types of providers, all of which are experts in the care of women from the time of menarche, which is first period, through menopause. We have OBGYN, MD /DOs, which are medical doctors or doctors of osteopathy. And these are providers that are experts in women's care across the spectrum. So they'll see women from their first period all the way through menopause and beyond. They have surgical expertise, and they tackle a lot of the complex issues that can arise in gynecology. We also have certified nurse midwives. That's what I do here, and my partner, Michelle Rice, as well. We are experts in healthy women from the time of their first period through menopause, but we really do a focus on those childbearing years. So during pregnancy and birth is when we see the majority of our patients. And we do not perform any sort of surgical procedure. So if we are seeing somebody for a gynecology visit and they need further care, then we'll usually have them follow up with one of our doctors. And we also offer a women's health nurse practitioner. Her name is Brenda Ryder. She's also an expert in healthy women. She sees mild to moderate complexity patients. So if there's a little more challenging gynecological cases, she may visit with them and, again, send them to our doctors if needed. She does not perform surgical procedures, and she does not perform births. I think total here at the clinic right now we have 7 doctors on campus that focus on gynecology and obstetrics. We have 2 midwives, and then we have 1 women's health nurse practitioner. Why do women need to go see the gynecologist? Well, they come to see us for a variety of reasons. First of all, they may come to see us to talk about their menstrual cycles. They may want to talk about what their options are for birth control. They may need testing for sexually transmitted infections. We used to call that sexually transmitted diseases, but the terminology has changed a little bit over the past few years. And they may just have general questions about sex or sexuality. Those late teen years, early adult years can be challenging for a lot of women. They may come in for just testing for vaginal infections that aren't sexually related. So these might be urinary tract infections, other vaginal infections that we see like yeast infections or bacterial vaginosis. They'll come and see us for breast concerns. Maybe they've noticed some changes in their breasts, new lumps, nipple discharge, or there's something going on. They come to see us for their annual well woman exam. I think this is a good population that we see frequently in clinic on a day-to-day basis. And that's usually every year from the time they're about 18 or 19 on. And then we see women for birth control check-ins. So if a woman's been recently started on a new birth control, we'll have them come in usually about 3 months after. And then we also want to see them yearly. And then they'll also come to see us for pregnancy confirmation or if they're having concerns about a current pregnancy. Is there a certain age to see the gynecologist? Well, appropriate patients for us are going to be someone who's already had their first period. I think that's an important piece. And then we also see them as they transition from that pediatric care to their well woman care, so somewhere between that 18 and 19 year age. The exception to this is if you have a daughter or a loved one who hasn't had her period by age 16, that would be another time that we definitely would want to have them come in and see us as well. What kind of visits are not appropriate for gynecologists? That would be pediatric well checks. So again, if you need that yearly exam for school and children, 18 and beyond or 18 and under, if you're looking to have a sports physical completed. Primary or urgent care, the exception to this would be if you think that you or your daughter has a bladder infection or some sort of a vaginal infection or breast concern, then we would definitely see them. But if it's strep throat or asthma flare-up or something like that, that would be something that you'd want to see a primary care provider for. Preoperative physicals, unless it's gynecology specific, we do not see those patients. Mental health, so if you have a daughter or a loved one who has having an experience with depression or anxiety, and you need an initial assessment or you need long-term care, they should follow up with a mental health provider. And management of chronic disease. So that's going to be patients who have a history of asthma, have a history of diabetes, hypertension. Those long-term conditions are going to be something that primary care will follow through. Who should come to the visit with your daughter? There really are no rules about who can come. I think it's whoever your daughter feels most comfortable bringing should come. And I think it is nice if they bring a second person just because I think they can become overwhelmed in the visits and sometimes they don't hear all the information that we're trying to educate them about, and having that second set of ears can be really helpful. So that could be a parent for sure. I see a lot of moms and daughters in clinics together. Every now and again I'll see a dad. Friends or peers, especially when we talk about birth control visits. A lot of friends like to tag along and hear the information. Anybody that is a confidant to your daughter, maybe is a teacher or an aunt or a cousin, they're welcome to come as well. And then siblings. We see siblings quite a bit in clinic as well, especially when they're close in age to your daughter, just so that they can kind of be on the forefront of that information that we're providing. And they can also come alone. We don't see that a ton in clinic, but they certainly are welcome to if that makes them most comfortable. Our visits confidential. They are. We follow the same rules as any other healthcare facility. So any information that's talked about during clinic visits is kept between the provider and the patient. Any exams, any lab results, any prescriptions are all between the provider and patient as well. The only time we would sway from this is if there was a safety issue, if we had concerns about abuse or that we didn't think the patient was safe. We certainly would have to speak out about that. And that also, the confidentiality also holds true when we talk about birth control. So your daughter does not need to have parental consent to come and receive a birth control prescription. Anything they choose to do, they can pretty much do here at the clinic with us. General visit flow when they come in is going to be very similar to any other visit you're going to have here at the clinic. There will be a check-in desk. Your daughter will be brought back to the room by our medical assistant. She'll take her blood pressure, talk to her about why she's coming into the clinic, review her medical history briefly. The provider will then come in and meet with the patient as well, do a lot of those similar things. So we still go back through and review your medical history, your surgical history, family history, medications, those kinds of things. And then if a physical exam is appropriate, then that will occur. And then we'll talk about recommendations and plan for what your follow-up care should be, and then you'll check out on your way out. Average visits for us last somewhere around 20 to 30 minutes. If you think that you have a pretty complex issue when you schedule your appointment, you may want to ask for an additional 10 minutes just so that we can make sure we cover that. And sometimes a second visit may be needed as well. Expectations about what the gynecologist will do during the visit. Again, like I spoke of earlier, we're going to review that medical history, your surgical and family history, and also your menstrual history, your daughter's menstrual history. We want to know when she had her first period. We want to know when her last period was, what her cycles have been like, how long they last, are they painful, does she have cramping, is there bleeding heavy, any clotting, those kinds of things are important during a gynecology visit. We also review medications, any allergies, and also immunizations. So is she up to date on her Gardasil, which is the HPV vaccine? Does she need a flu shot? Those types of immunizations would be offered if needed. We'll perform a review of systems, which is where we ask questions like, do you have a history of headaches? Do you have a history of asthma, hypertension, those kinds of generalized questions. And then a physical exam if it's appropriate. It's not always necessary, and we'll talk about specific visit types later here in the presentation, but generally speaking, it's about a 50-50 split between if we're going to do a physical exam or not. And we don't do pap smears anymore before age 21, which I think is a huge change for a lot of the public. That probably occurred within the last 10 years. We used to do pap smears yearly on women from the time that they came to see a gynecologist through menopause. And now the research has supported that that doesn't need to occur anymore until you hit 21. And once you are 21, those pap smears will occur every 3 to 5 years. So that's a big shift in how we perform our exams. We do routine lab testing, and that will be chlamydia testing is the main routine testing we see, and that's a urine sample. We'll prescribe any medications that may be needed. We'll review your AVS, or it's called an after-visit summary, and so that's a document we give you at the end of your daughter's visit that goes over anything we discussed during the visit, any prescriptions, any labs that we need to have happen. So it just gives you a nice layout, and then we talk about when you should follow up and come back and see us again. So let's go see the gynecologist. I think it's helpful to understand how menstrual cycles in young women work. So the average age of a first period is going to be somewhere between 12 and 13 years old in the United States. 90% of girls will have a period by the time they're almost 14, 98% by the time they're 16, and less than 10% before age 11. During those first 3 years when they start getting their periods, the intervals between their cycles are going to vary. So somewhere between the 21 and 45 days is not abnormal. And when we're talking about counting those days, you want to start from the time the first day of the period is to the first day of her next period, and that's your actual interval. Most periods during that first 3 years are going to last less than 7 days. Sometimes they're only going to be, 1 to 2 days. Some days maybe, or some cycles maybe 3 to 4 days. But by the third year of their cycle, they'll be back into a more adult-like pattern where they're having periods every 21 to 34 days. Most will last somewhere between 4 to 7 days. If you take a peek, it's kind of hard to see the picture there, but it's image that I use quite a bit in clinic when I'm talking to young women about their periods. I think it lays out what's happening in their body. You can kind of see how the egg develops and releases. On the bottom of the graph, you can see how the uterine lining thickens over time, over the month, and then it sheds, and then it thickens. And it's also nice to talk to them about their hormones, too. You can see the estrogen levels and the progesterone levels when they peak, at what day in their cycle. On the bottom there, it shows you 0 to, I think, 28 days there. And when their progesterone peaks and cycles as well. So one of the most common visits we see is going to be a menstrual cycle visit. This may be a time that we do a physical exam or we may not do a physical exam. Many young ladies who come to see us for this type of visit are usually feeling pretty isolated by their periods. Maybe they're having really heavy bleeding, they're having really crampy periods, and this is all new to them, and so it can be kind of a difficult appointment for them. I think they feel awkward and uncomfortable. And so things we talk about would be primary amenorrhea, which is when they haven't had a period by age 16, or secondary amenorrhea. This is when they've had a first period, but then they have 3 cycles where there's been no bleeding, or a total of 6 months with no bleeding when they have had that first period. And then we see women for dysmenorrhea, which is painful periods, so that heavy cramping, maybe they're missing school or missing work, and that's a good time to come in and see us. And then if they're having those heavy periods, maybe they're soaking through their tampons and their pads in less than 2 hours, they're passing clots, periods are lasting longer than 7 days, that's an excellent time to come in and see us as well. I think I'll take a break here to see if anybody has any questions. There. All right. It looks like I have a question. So in a wellness exam, the parent has to leave the room for a period of time. Is this the case for the gynecologist exam? I'm actually going to address that shortly here. The discussion is between the patient and her parent. They do not have to leave the room, although if you're going to stay in the room, we will ask that you kind of hang out by the head of the bed, especially if there's going to be any sort of a pelvic exam. But that's really a discussion you and your daughter should have prior to coming in and seeing us so that we can kind of gauge what the comfort level is and if you're going to stay or if you're not going to stay. And clarify prescription age if your child is on your insurance and using that. I think parents are notified even through the payment. I think the question is is there's a certain age that we provide prescriptions, and technically there isn't. Again, we usually want them to have a first period, and if your child is on your insurance, you would see that come through when you're using a private clinic. You would see that come through on your insurance bill. And what's the value of going to visit a gynecologist versus a primary doctor that is a GP? I think the biggest benefit is that we focus on women's health. That's all we do. We don't see men. We don't do children. So we're very in tune with what's going on with women's bodies, specifically uteruses, breasts, ovaries, those kinds of things. And so, I mean, if you have a very established relationship with a general provider and you're comfortable with them seeing your daughter, for sure that's an option. It's not something that you have to see a gynecologist, but if there are concerns or problems in those areas like breast, uterus, vagina, then I think that we can be an excellent resource for you and for your daughter. All right. Let's see. So we're going to proceed here. Another visit type that we do frequently is the birth control visit. Usually there is not a physical exam attached to this visit. Birth control is used for numerous issues with young women. We use it to prevent pregnancy. We use certain types to reduce the risk of sexually transmitted infection, to help with menses or help with their periods and regulate those, improve acne, and reduce PMS symptoms, so moodiness, maybe some symptoms of anxiety or depression, either throughout their cycles or at the beginning or end of their cycles. A very effective method of birth control that we see quite a bit now in our older teens and young adults are IUDs, or intrauterine devices. There are several types that are available. There are hormonal IUDs, and there is a non-hormonal IUD. The hormonal IUDs on the market right now are called Mirena, Kyleena, and Skyla. They all have progesterone only as their hormone. They're excellent sources of birth control. They help regulate menses. So for women who are having really heavy periods or having painful periods, the IUD can really help decrease and sometimes even eliminate those periods sometime in that first 6 months to a year after placement. And depending on which IUD you use, they last somewhere between 3 to 5 years. The non-hormonal IUD is called Paragard. It's a copper IUD, so it is strictly for preventing pregnancy. Its lifespan is 10 years, so it's a very long IUD. Women who would not be good candidates for that are going to be women who have heavy periods or cramping. Typically, we see that bleeding gets worse with a Paragard IUD, as well as cramping can increase as well. So women who would be a good candidate for this are going to be women who have very minimal periods, who are just looking to prevent pregnancy. Any of these IUDs are going to be irregular bleeding. It's not uncommon for the first 6 months to 12 months that you're going to have irregular spotting, periods that maybe they're not expecting, and that can be frustrating for sure. I always have my patients follow up 6 weeks after an IUD placement, and then again somewhere in 6 months to a year, just to see how the bleeding is going, to see if they're tolerating that or if they're not. There are a couple things we can do to help kind of tweak that bleeding if needed, and it doesn't protect against sexually transmitted infections. So any of these birth control methods that I'm going to discuss, we really focus on also using condoms in conjunction with the birth control to prevent those sexually transmitted infections. NEXPLANON is another excellent method of birth control. It's a small implantable rod. You can kind of see in the bottom of that photo, there's a white rod down at the bottom. It's about 1.25 inches in length. It's placed in the patient's non-dominant arm, kind of on the inside of the arm, between those two muscles that you kind of feel on the inside of your arm there. So it's a device that you can feel. She'll know that it's in place, but you don't necessarily see that device. It lasts for 3 years. It only has progesterone in it. It does not have an estrogen component. The pros is that it's relatively non-invasive. We don't have to do a pelvic exam in order to place that. It's just through the arm. It's excellent birth control. It has the highest effective rate of preventing pregnancy on the market right now. The cons are going to be it also has an irregular bleeding profile. And in comparison to an IUD, I tend to see worse bleeding with the NEXPLANON. Women get frustrated with that. Usually somewhere around that 3 to 6 month mark after placement, where they're having irregular bleeding, periods they weren't expecting, heavier periods. Occasionally we'll see women who stop having periods altogether with the NEXPLANON. Most women will fall somewhere in the middle where they're going to have those irregular bleeding at least for the first 6 months to a year, and then they either are comfortable with the new normal or they come back to see us to have it removed. And again, this does not reduce their risk of sexually transmitted infection. Oral contraceptives, those are your birth control pills. We still prescribe those frequently in clinic as well. There's 2 types on the market. There's combined hormonal contraception, so these are going to have your estrogen component and a progesterone component, but they're not an option for women who have a history of migraine headaches, liver disease, or clotting disorders. And then there's progesterone-only pills. They're commonly referred to as mini pills. The PROVERA pills they help prevent pregnancy. They may help improve your daughter's acne, help regulate their menses or their periods, and may help elevate moods if they're having some difficulties there as well. The cons are that they have to remember to take their pill at the same time every day, and that can be tough for young women who have busy lives and sports and work and school. So I think with the smartphone has really helped with that. They can set an alarm every day and they're much better about taking that on time, but it can be a nuisance for them. And again, pills do not reduce their risk of sexually transmitted infection. Birth control patches. These are removable patches that your daughter would change weekly, and they do contain, similar to the pill, an estrogen and a progesterone component. They're nice because your daughter controls her birth control. She takes the patch on, she takes the patch off. They may help with regulating their periods a little bit. Like, again, they have to remember to change their patches every week. There is some research on weight restrictions with patches. So if your daughter is greater than 250 pounds, it may not be as may not do as well of a job at preventing pregnancy as some of our other options. And again, it doesn't protect against your sexually transmitted infections. NUVARING is a flexible ring that has estrogen and progesterone. It's placed vaginally every 21 days. The pros are your daughter can kind of set it and forget it. She's got 21 days where she doesn't have to think about her birth control. But at the end of that 21 days, she does. She has to remember to take the ring out. And it can help with menses regulation, too. Again, the cons are going to be they have to remember to take that ring out. The hormones only last for 21 days, so if she forgets to take it out, she would be at risk for pregnancy, and she has to be comfortable touching her own body. And for a lot of young women, that can be a challenge, and so it may not be an appropriate method for them. DEPO PROVERA injections, this is something that we do in clinic. It's a intramuscular injection that we give every 3 months. It has progesterone as its hormone. It is excellent birth control. And typically within the first 6 months to a year, women will have a reduction in their periods and may have no period at the end of that first year. The cons are that they have to come in every 3 months for their injection, and so that can be challenging with their schedules. And there is a black box warning with the DEPO injection, and the black box warning is regarding calcium. So while your daughter is using DEPO PROVERA injections, her bones will not as readily absorb calcium. At the end, when she's done using it, her bones will bounce back and reabsorb that calcium back. But during that time, it's important that she has at least 4 servings of calcium per day to protect her bones, and those servings need to be spaced throughout the day. So she doesn't want to have, milk and a yogurt at breakfast. She needs to have milk at breakfast, a yogurt at lunch, something at dinner, and then something before bed, so that her body can adequately use the calcium that she's taking in. It does have proven weight gains. A lot of young ladies are not a fan of that. The weight gain is averages about 5 pounds for the first year and up to 5 pounds for every year thereafter. And again, it doesn't protect against those sexually transmitted infections. Condoms, they're readily available, so they're great that way. Your daughter can get them at the gas station or at Target or CVS, pretty much anywhere that sells drugstore-like products. And if they're used properly, they can reduce the risk of STIs. But the cons are you have to know how to use them properly, and your partner has to know how to use them properly. And so it's not an excellent method of birth control. There's a lot of room for error if condoms are your only birth control method. Testings and screenings for sexually transmitted infection is another visit type that we see frequently here in the clinic. Likely a physical exam would be needed for this type of visit, but not always. Routine screenings that we do are going to be for chlamydia. Chlamydia, we see it quite a bit in the clinic. Women usually have no signs or symptoms when they have a chlamydial infection, and long-term risk with that is infertility. So it's important that we screen them, and the CDC recommends annual screening from ages 16 through 25. If your daughter is not sexually active or doesn't need a pelvic exam, then we screen through a urine sample. But we can screen through a cervical or vaginal sample as well. Pap smear is another screening. Again, we don't start pap smears until age 21. And based on the results of that first pap smear, we usually recommend that they have that performed again every 3 to 5 years. And that's using a cervical sample, so a pelvic exam is needed to collect that pap smear. And HPV or human papillomavirus, typically we do routine screenings with that at age 30, and it's usually combined with a pap smear through a cervical sample. If your pap smear is abnormal between ages 21 and 30, then we routinely will automatically check for HPV as well. But if it's a normal pap smear, then we will wait until age 30 for that. Sexually transmitted infections that we see in clinic are going to be bacterial vaginosis, and that can be a sexually transmitted infection or a non-sexually transmitted infection. We test for that using a vaginal sample. Gonorrhea, again, we use a vaginal or a urine sample for that. Genital herpes can be tested through vaginal or through blood. Hepatitis B and C is usually a blood sample. Human papillomavirus can be a vaginal or cervical sample. Pelvic inflammatory disease, vaginal samples, and blood testing as well. Syphilis, which we are seeing an uptick in the Twin Cities area in syphilis, is a blood sample. Trichomoniasis, I apologize, that should be a vaginal sample. HIV or AIDS, we use blood sampling to test for that. And chlamydia, that should be vaginal or urine, not blood. My apologies. We also see women for those vaginal infections that are non-sexually transmitted or urinary tract infections as well. Physical exam is usually needed during these visits as well. Sometimes it can be challenging to figure out is the discomfort or the symptoms coming from the vagina? Are they coming from the uterus? Are they coming from the bladder? They can all be interlinked, and so we'll probably check a urine sample, and then we may also do a pelvic exam and check a vaginal sample looking for bacterial vaginosis, yeast, or trichomoniasis. Breast concern visits. We'll need to do a breast exam if your daughter is presenting for this kind of a visit. Breast development typically begins somewhere between 18 and 24 months before their first period, and then that development will continue till age 17 to 21. We see women in clinic or young women in clinic for breast lumps, nipple discharge, breast tenderness, breast changes. Sometimes that can be a dimpling, a color change, anything that is new to them. If they have concerns, they should definitely come and see us. And then we do birth control check-in visits. I think I mentioned this earlier in the presentation. So when we start somebody on a new birth control method, we usually have them come back 3 months after we start that method to check in. We want to check their blood pressure, see if they're having any side effects, if there's been any changes in their health history. And if everything's going well, then we usually have them come back in a year from then or when they're due for their next annual exam. Pregnancy confirmation or management. We do quite a bit of pregnancy testing here in the clinic. That can be done through a urine sample or a blood sample. We do counseling and either for positive pregnancy or for negative pregnancy, and then review any birth control options and safer sex. If they're not pregnant, then they want to discuss that. If they are pregnant, then we talk about prenatal care. Final visit that we see quite a bit in clinic is going to be your annual well woman visit. We do a physical exam with this, not necessarily, though, a pelvic exam. This is a yearly exam that we start at about age 18 to 19, I think is pretty much the norm right now. And this is a great time for us to just talk about education regarding healthy habits and lifestyle, healthy eating habits, healthy exercise, those kinds of things, and talk about preventative care. It can be confusing to women, so we want to see women every year for an annual well woman exam. They may not need a pelvic or a pap smear but every 3 years, or maybe not even that more frequently, but we still want to see them in clinic to do a breast exam, to update their health history, to listen to their heart and lungs, answer any questions they're having about their periods, any questions about birth control, those kinds of things. So it's important they see us every year. And like I said, a physical exam, we're going to do a head-to-toe exam, including a breast exam. The pelvic exam will vary. And again, we're not going to do those pap smears until age 21. So to review, we just want to talk about it's important to establish that trusting relationship with a provider at the appropriate age. These can be lifelong partnerships. If we see your daughter or your loved one early on in her late teen years or early adult years, it may be a relationship that we see into her 20s, 30s, 40s, and 50s. And I think that can be really beneficial to both the patient and to the provider. When you come to the visits, come prepared. If you have questions or concerns that you know you want to get addressed, I think coming in with a list can be very helpful. And sometimes we'll need to, if it's a extensive visit, we may have to break it into two different visits to make sure that we cover all the information that you're interested in. And then when you're in the visit, just to respect any boundaries that you and your daughter have. So if she would like you to step out of the room, that you respect that. If she's comfortable having you in the room throughout, but you're not comfortable, then talk about that beforehand too. That sometimes will occur. And I always think it's nice if your daughter or loved one can actually lead the visit. So when we come in, I like to talk to her first and see what her concerns are, and then include you in that conversation as well. And then plan for privacy. Again, we want to meet together as a team, talk about concerns, and then when it's appropriate, have a support person step out if that's desired by both the patient and her support person. That concludes my presentation. I'll see if there's any additional questions now. Don't think that there are any new questions. I'll sign off for now.
Thanks, Lauren. That was very informative. We'll just hang out for another minute. If you have any questions, please type them in for Lauren. And really appreciate you joining us today. If you have, I'll send out the recording later this week, and there's a survey with that. If you have suggestions for other webinars, really appreciate that. We try to provide something of interest to you. Give it another minute if you have any questions here. I see the question is, are the slides going to be available with the recording? And yes, I can provide a PDF of the slides for you. Okay, I think we have another question here. Just to thank you, and we appreciate that, and we will sign off now. Appreciate you attending with us. Thank you.